Ganesh Prabhu.
Ganesh Prabhu, mute பண்ணிக்கலாம்.
Share screen தெரியுதா?
தெரியுது, clear.
Clear, okay.
Yeah, we are on time, Kripa, start 11. Ready to start.
Ready?
Yeah, Shilpa, you can mute everyone.
Yes, sir.
Okay to start, Kripa.
Am I audible now?
Yes.
Okay. Good morning all of you. It's a great pleasure to meet all of you again after a gap of 1 week with the webinar 9 by Tamil Nadu ISA hosted by ISA Chennai City. We thank ISA Chennai City for their cooperation, and I want to make 3 announcements here. First is kindly note down the Tamil Nadu ISA WhatsApp number here. Okay, you have to send your name alone to this WhatsApp number. Okay, don't send your other details. Just send your name alone if you need a credit hours for this program. Okay, then and we have formed some rules for the chat box. Don't type your name or mobile number or any other details in the chat box during the academic program. Chat box should be used only for typing the questions, asking the questions alone. Okay, so don't use the chat box. Don't type your name or mobile number or any other details in the chat box. Okay, then the third thing is chat box should be used only to type your questions for the speakers. And we are happy to announce our Tamil Nadu ISA PG Conclave 2020 that will be conducted on 18th, 19th, 20th of December. The details will be announced soon before the academic program. So now I welcome Dr. Anuradha Magendar, President of Chennai ISA, to give a welcome address. Dr. Anuradha, please.
Am I audible?
Yes.
Yeah. A very good and happy morning to all the ISA members. At the onset, I would like to welcome our National President-elect Venkatagiri sir, State ISA President Dr. Sudarshan, State ISA Secretary Dr. Kripakaran, Treasurer Dr. Ratnakumar, Vice President Kumar, GC members Ganesh Prabhu sir, Academic Coordinator Dr. Edward Johnson, past National ISA dignitaries Dr. K. Balakrishnan sir, and my dear Chennai City ISA members. A good morning to one and all. This idea of conducting a weekly webinar was a brainchild of our Tamil Nadu State President and Secretary of having this webinar every Sunday. They have successfully completed 8 webinars and ours is the 9th. So we have 7 more to go. We have not only, through these weekly webinars, we not only get a scientific feast, we also get to know about the activities of that particular ISA branch through their secretary report, which gives a confidence and the motivation for the particular ISA to do much better. Today we have 2 eminent speakers. One is Dr. Ranjit Karthikeyan, who's going to talk on pre-op echo evaluation, and the other is the post-op pain management, the current understanding, by G.K. Kumar. Whether we get our Sunday biryani, this webinar is definitely a feast for our ears. Wishing a grand success for this weekly academic program. Thank you.
Thank you, Dr. Anuradha. Now I invite our State President, Dr. Sudarshan, to give his address. Dr. Sudarshan, please.
Good morning, everyone. Respected President-elect Dr. Venkatagiri, GC member Dr. Ganesh Prabhu, past presidents, senior past presidents of ISA National, Professor Dr. Balakrishnan, Dr. Kameshwar Rao, Dr. Chakra Rao, past National Vice President Dr. Meenakshi Sundaram, sitting office bearers of ISA Tamil Nadu, my dear colleagues, all the presidents and secretaries of city branches from all over the state, President of ISA Andhra Pradesh, Dr. Venugopal, and all the dignitaries who have invited and attending this webinar regularly, and most importantly, all the delegates who have been constantly successfully motivating us to carry on with this academic activity week on week. And that gives us the enthusiasm to continue, and I'm sure it will complete the whole circle of all branches within the next 7 weeks, most likely. And within these 7 weeks, we have few other programs very importantly lined up. We are, as per request of the postgraduates, because the postgraduates need to sort of complete paper presentation in order to secure their exam hall tickets for the university. So in order to complete the requirement for the postgraduates, we are compelled and also we are happy to host online program, PG Conclave, in the coming month, which is in the month of December. The details will be shared by our secretary shortly before the academic event starts. That will be primarily focusing on postgraduate presenting papers, and the posters, e-posters, everything will be an opportunity. It will be a 3-day event, continuously will be done Friday, Saturday, Sunday in December 18, 19, 20. And the program will be completely online one. And we request all the head of the departments of every medical institution to kindly cooperate, encouraging your postgraduates to start preparing from now on, to prepare and present the papers as many as they could, so that they will have the opportunity to present, and we are ready to get the credit points from the medical university and as well as the medical council, so that it will be very useful for them. So with this little announcement, I'm happy to announce this weekly webinar to start, and also to continue. And we have another program at the end of this PG, every weekly webinar as a summit program, one full day online event is a Tamil Nadu sometime in the month of January. So continuous academic activities are being prepared and planned for the benefit of all our members. I'm sure it will be not stopping with that, and with the support of all you people, we will continue to do our good work with the blessings of Lord Almighty. With that little words, I thank you and enjoy your day. And we have wonderful speakers today. Dr. Both the speakers are very well known to you. Ranjit is well known on its online platform, and Kumar is a known person in the pain circles and also who follow him very well for the past 15 to 20 years. So enjoy your academic program today. Thank you so much for the opportunity. Over to Kripa.
Thank you, Dr. Sudarshan. Now I invite Dr. K. Balakrishnan, our past state ISA Tamil Nadu president and as well as ISA national president, and also he's a mentor for all of us. We are happy to welcome Dr. Balakrishnan to give his felicitation address today. Dr. Balakrishnan, sir, please. Sir.
Sir, unmute, sir.
Sir, you please unmute, sir. Bala, sir. Bala, sir, please unmute yourself. Left side. Okay. Yes, sir. Yes, please.
Good morning to all. I'm happy that the Chennai City branch of ISA and the Tamil Nadu State branch of ISA is making use of the modern technology. It's a great boon in the absence of actual meetings. It is facilitating the gathering of the like-minded people to discuss, share, and exchange their knowledge in their home itself by webinar and virtual meeting. By this, it is an attempt to spread knowledge to all by invoking the cooperation of the academically interested faculty to discuss the topics of importance for the benefit of the practicing anesthetists and the trainee anesthesiologists. ISA Chennai city branch and Tamil Nadu state branch must initiate more members to make themselves interested, not only in the academic activity, but also in the national ISA level participation. In 1990, Dr. Vijay Appukutti became the president of the ISA, and in 1992, I became the secretary of the national ISA, and Dr. Samandam became the treasurer. In the year 2000, I was elected as the president of the ISA, and in 2010, Dr. Ranganathan of Salem became the president of ISA. And after that, only notable thing was Dr. Meenakshi Sundaram became the vice president. After that, there are only 3 people representing the National ISA's governing council members. This must change. In today's meeting, there are 2 well-known speakers from ISA, Dr. Kumar talking about the postoperative pain relief, and Dr. Ranjit Karthikeyan talking about the importance of echo for the anesthesia. In this COVID lockdown, we anesthesiologists are facing a lot of challenges. My wishes are with them. I take great pleasure in participating in this virtual meeting and hope all of you will be benefited from this. Thank you very much.
Thank you, sir. Thank you for your blessings. Now, I want to give some elaborate announcements regarding our PG conclave. Is it visible?
Make it full screen, Kripa.
Yeah,
Yes.
visible. Yeah.
Okay. Yeah.
So as Dr. Sudarshan said, it will be conducted on 18th, 19th, 20th of December. Presentation of e-paper and poster.
Your voice is breaking.
Will be
Shilpa?
Yes, sir.
Why Kripa is gone or what is happening?
No, he lost his internet connection, I guess, sir. Sir is not there in the booth.
Oh, I thought I lost mine. So it doesn't matter. You go ahead. If that is the case, you should have warned me. It doesn't matter. So Kripa wanted to make an announcement regarding the event which is going to be held. Are you able to hear? Am I audible?
Yes, sir. Yes, yes.
Okay.
I'll.
So I thought we were wasting time. Doesn't matter. So without losing time, we should start and go ahead. Over to Edward. The announcement of the program can be made latest time because we are already running 11:14. We should be on the academic time now. So over to Dr. Edward. Let Kripa join when his internet is okay.
Kripa sir joined.
Doesn't matter.
Am I audible?
Yes, Edward. Please go ahead. Yeah.
So I welcome you all for the 9th CME of Tamil Nadu ISA. It is sponsored by Chennai ISA. There is an important announcement which was interrupted. It is a digital forum of research paper presentation we are planning to conduct on December 19th and 20th. It has two categories.
Edward, sir, you have joined in 2 devices. Can you just close any one device?
It is echoing. You can mute the other device, doesn't matter.
Please one.
I think we are having a good start for the PG conclave. We have been a lot of interruptions for that.
The PG conclave has 2 categories of presentation. One is e-paper presentation, another is the e-poster presentation. The judges will select 10 top papers of e-paper presentation, and it will be a live presentation on the 20th December. And the remaining papers will be called as free papers. It will be presented at 18th and 19th, and the best 3 papers will be selected from the free papers also and the competitive papers also. And there is 3 more presentation in the e-poster category also. It will be a pre-recorded one, and all other guidelines you can see in the website. It will be posted in the Tamil Nadu ISA website. So the registration is must for all participants, and it is only open to the postgraduates. So coming to this week academic event, today's topics are presented by a well-known speakers and the stalwarts of the respective field. The first topic is the preoperative echo evaluation, what an anesthesiologist should know, by Ranjit Karthikeyan. And the second topic is the postoperative pain, current understanding and management, by Professor G.K. Kumar, the president of Tamil Nadu chapter ISSP. Our chairpersons are also well-known stalwarts on the field, respective field. Dr. S. Kumar, he is a senior consultant and head of cardiac anesthesiology and critical care of Meenakshi Mission Hospital, Madurai, and he is a president-elect of Tamil Nadu ISA, and he has more than 20 national and international publications on his credit, and he is the scientific chairman of the well-known academic event that was conducted in 2014 at Madurai, the ISA-Con. And the second chairperson is Dr. Gurumurthy. He is a consultant anesthesiologist and pain physician of Kaveri Hospital, Trichy. He has a fellowship in ASCLPA and FIPP and cardiac anesthesia. He has presented many papers in the national and international conferences. He is the present MD of Dr. Guru's Pain Care Clinic, Trichy. I welcome you, sir. So we will start with the academic event. Over to the chairpersons, Kumar and Gurumurthy. Please introduce the speakers and we'll start the academic event.
We would also acknowledge presence of Dr. Harsur, past president, ISA National, Dr. Yeah, please go ahead, Kumar.
Yeah, okay. Thanks, Edward, sir. Respected national office bearers, our state GC members, ISA State Tamil Nadu office, our president, secretary, treasurer, and academic coordinator, past presidents of ISA National as well as Tamil Nadu, all the branch president and secretaries, members of ISA, postgraduates, and my dear colleagues. A very good morning to everyone. Though I am part of it, I congratulate our ISA Tamil Nadu State Office, headed by our President Dr. Sudarshan, our Secretary Dr. Kribakaran, our Academic Coordinator Dr. Edward Johnson, our Treasurer Dr. Ratna Kumar, for successfully conducting this weekly webinar in a regular and a very well appreciable manner. Thanks to our Chennai ISA team, Dr. Anuradha ma'am, Dr. Bhaskar, Dr. Giri, for hosting this event. Today we have 2 very interesting topics, pre of echo evaluation and post-operative pain management. Both the topics are very useful in our day-to-day clinical practice. For delivering the lectures on these topics, we have an excellent and experienced speakers, Professor Dr. Ranjit Karthikeyan and Professor Dr. G.K. Kumar. The first topic will be on preoperative echo evaluation, what the anesthesiologist should know. With an aging population that continues to increase, we have many patients with a cardiovascular risk factors or a pre-existing cardiovascular disease when they coming for non-cardiac surgery. Among the available diagnostic imaging modalities, the echocardiography plays a major vital role in the preoperative cardiac risk assessment as well as risk stratification. So we, the anesthesiologists, when we approach the patient coming for non-cardiac surgery, for any surgery, for the sake, for pre-op assessment and risk stratification, we should know, number one, the indication for pre-op echo as per the current guidelines. Number two, the application of echo in real-world clinical practice. Number three, most importantly, the correct understanding of commonly encountered echo findings, which may help in the management of patient in the perioperative period. So to talk about these things, we have an excellent speaker and a very good friend of mine, Professor Dr. Ranjit Karthikeyan from Sri Ramachandra University, Chennai. It doesn't need any introduction to this esteemed audience because his raw online speaks volume a lot that made him popular to the India and to the many parts of the world also. He is currently the professor and head of cardiac anesthesia at SRMC Chennai. He has more than 50 national and international publications. He has been the executive council member of our national IACTA twice and also the section editor of ANELSA cardiac anesthesia. And also he created the website for the database for IACTA. He created a very popular anesthesia website, Raw Online, Ranjit Anesthesia Academy Online. The proprietor come MD of Raw Online, which is one of the best website for e-learning in anesthesia in India. It is also well appreciated all over the India as well as in many parts of the world. For Raw Online and also for the contribution of many academics in the field of anesthesia, he has received many awards. To mention a very few, Academic Excellence Award in GARC 2017, International Summit Award for the use of technology in healthcare in Portland, USA, and also Best Medical E-Learning Website in the year 2017. So with this very brief introduction, I invite Dr. Ranjit to deliver a talk on pre-op echo evaluation, what the anesthesiologist should know. Over to Ranjit, please.
Good morning, one and all. I'm audible?
Yeah.
Well audible.
Yes.
Yeah. It is a great privilege to be among the stalwarts of all ISA Tamil Nadu. And I thank Dr. Bhaskar and Dr. Anuradha Madam for giving this opportunity. And it is a great privilege to be moderated by my good friend Kumar, who was instrumental in making me talk at the first instance. With this background, I'll just, without wasting much time, I'll go to the presentation. Hi all, welcome to Ranjit Anesthesia Academy. Today we are going to deal with a very important subject that all anesthesiologists should be aware of. Okay, look at this pictures. Basically, I'm from Chennai, from India. Here you can see a lot of greens, which is very, very unusual in Chennai. And there is an entity called Bus Day in Chennai, where people stand over the bus and dance to celebrate Bus Day, which is on May 1st. And here you can see some temple renovation going on. Apparently, Tamil Nadu is very famous for temples, so they keep the temple very clean. And you can see some work is going on the top of the temple. This is like your echo report, what cardiologists give. You look at the ejection report, It will give a rosy picture and you are happy to anesthetize. But if you have a good knowledge of what is happening inside the echocardiogram, this is what the real picture is. You can see the entire vehicles being submerged in water, and people are not celebrating bus day. They are standing over the bus to save their life. And here you can see the people are climbing over the temple to save their life, not to clean the temple. Your echo report is exactly the same. By looking at the ejection fraction, you are going to anesthetize. That means that there is a danger waiting to happen. You have to understand each and every variable which is there in the echo report before anesthetizing a case. It is not so difficult. Why you have to know about echocardiogram? The classical class 1 indication for a perioperative echocardiogram is acute hemodynamic instability. As an anesthesiologist who anesthetize any case, you might face this situation. Hemodynamic instability can happen very frequently. At the time, and sometimes you may not know the etiology. At the time, echocardiogram will come in handy for the diagnosis. At the time, you can't say I have no knowledge about echocardiogram. So you should have a basic minimal knowledge of echocardiogram in the perioperative period. So this is the standard echo report. What we do, we just look at the last line, ejection fraction. Okay, ejection fraction is normal. We'll go ahead and anesthetize the case. But if you look at the echo report properly, here you can have the dimensions. Here you look at, you have a lot of volume parameter. Here you have the aortic diameter, LA diameter. And here look at the, here you have the velocity across the mitral valve, and each valve they are put separately, and whether any shunt is there. And they look at regional wall, which is very, very important in a case of ischemia. Then they look outside the heart to see whether pleural effusion or pericardial effusion is there or something outside the cardiac chambers. Then only they come for conclusion. So many things are there in the echo report, but what we do is see the ejection fraction. If ejection fraction is normal, we'll go and anesthetize the case. And another important thing which we do is you have to compare with the normal variables. Usually normal values will be available, and you have to put the patient value and you see whether the patient is apparently normal or not. And another important thing which you do is you take the measurement in diastole as well as systole, and you have to compare the systolic measurement and the diastolic measurement. This is the echo report. Before going into the echo report, before going into analyzing the echo report, I'll just show the 4 common views and the various structures involved in it. This is called the FATE. First, you put on the subcostal. This is the subcostal view. Second is the apical view. Here you can see the heart. Third is the parasternal view, where you put the probe directly over the heart. And fourth is the pleural view. And fifth is suprasternal, which is not usually coming under FATE. FATE is nothing but focus as a transthoracic echo. The first one is the subcostal, second one is the apical, third one is the parasternal, and the fourth one is the pleural. Okay, let us go into each view. Coming to the subcostal view. Here you place the probe at the subcostum and you point the probe towards the left shoulder. These are the 4 chambers you get: right atrium, right ventricle, left atrium, and left ventricle. In this view, you can analyze all the 4 chambers as well as the interatrial septum and the interventricular septum. Any ASD or VSD, you can easily diagnose in this view. Coming to the second view, where you place the probe towards the right shoulder. Here you can see the inferior vena cava. This is the inferior vena cava draining into the right atrium. Here you see the right atrium, and this is the inferior vena cava. This view is very, very important for the volume assessment. If IVC is dilated, you can come to a conclusion that volume is a little bit more on the higher side. Coming to the apical view. Here you place the probe on the apical part and place towards the right shoulder. You get initially nice 4-chamber view. Here you can see the mitral valve. Here you can see the tricuspid valve, mitral valve. Then you rotate the probe further, you get 2-chamber view. This is the left ventricle, left atrium, and you can see the mitral valve. Then you rotate the probe further, you get what is called the 3-chamber view. Here you can see the aortic valve, and this is the mitral valve. Okay. So in the initial part, you get a nice 4-chamber view. You can see the right ventricle, tricuspid valve, and the right atrium. Here, this is the right atrium, tricuspid valve, and the right ventricle. Then comes the left ventricle, mitral valve, and the left atrium. So you can assess 2 valves as well as the 4-chamber. This is for the two-chamber view is only for the mitral valve, and you can see the left atrium and the left ventricle. Then as you rotate further, you get nice three-chamber view. Here you have the mitral valve as well as the aortic valve, and the third chamber is going to be your right ventricle. This is the right ventricle, left ventricle, and the left atrium. That is called the three-chamber view. This is the apical view. This is basically for contraction and assess the mitral regurgitation and mitral and the aortic valve. And coming to suprasternal, you place the probe on the sternal notch, and you can look at all the great vessels. The one is the ascending aorta, and this is the brachiocephalic artery. This is the descending aorta, and this is the left common carotid, and fifth one is the subclavian artery. This is usually done when you have a problem with the great vessels. So now coming to the most important view, which is the parasternal view, long axis view. Here you can see the left ventricle, right ventricle, left atrium, ascending aorta, and then descending aorta. And you can see the pleural space. Here, right ventricle, left ventricle, aorta, mitral valve, and you can see the descending aorta, and some bit of collection is there. This is a pericardial collection, and this is the pleural collection. A large pleural collection is there. Okay, this view is very, very important in assessing the right ventricle, left ventricle, as well as the LA. If you place an M mode over here, you can get the measurement of the right ventricle, septum, left ventricle, the posterior valve, and if you place the M mode here, you can compare the aorta LA ratio, which is very, very important. I will explain about aorta LA ratio. Then coming to short axis parasternal view, you can measure the short axis at 3A level, one at the mitral valve, then at the papillary muscle, and then at the aortic valve. Here you can see the measurement of the aortic valve, and this is the mitral valve, and this is at the level of papillary muscle. This is mainly for assessing the various wall movement of the left ventricle. And another important thing is at the level of aortic valve, you can see the aortic valve as well as the RA inflow and outflow. Okay, you can measure the ASD here, or you can measure the TR here. And this is very important for RV outflow also. You can measure the pulmonary artery diameter, and you can calculate the cardiac output across the right ventricular outflow tract. This view is very, very important. Okay, you can see the contraction, you can see the right ventricle also. Coming to the last view, where you place the probe across the thoracic cavity to see whether fluid accumulates in the pleural cavity. Okay, you place the probe outside the chest on the intercostal space, and you can see whether any fluid collection is there. Here you can see little bit pleural collection is there. These are the four views we go. Now let us come to the most important parameter which you always look at. That is nothing but ejection fraction. What is ejection fraction? You measure your volume at end diastole and volume at end systole. Your diastole, your mitral valve will be open. In systole, the mitral valve will be closed. So you measure the volume in end diastole, you measure the volume at end systole. Okay. So your ejection fraction is nothing but your end diastolic volume minus end systolic volume by end diastolic. In another word, it is stroke volume by end diastolic volume into 100. The normal value is going to be 55 to 75%. This is the ejection fraction. If you do the same thing to the LV dimension, it is called the fractional shortening. You measure the diameter at end diastole and you measure the diameter at end systole. And you apply the same formula which you do for ejection fraction, like end diastolic diameter minus end systolic diameter by end diastolic diameter. You get what is called fractional shortening, which is represented as Fs in the echo report. The normal value is going to be 30 to 45%. Now you looked at the diameter. The third one which you're going to measure in end systole and end diastole is the fractional area change. Instead of measuring the diameter, you measure the area of the ventricle. Here you can see the end diastolic area, and here you measure the end systolic area. Again, you put the same formula, end diastolic area minus end systolic area by end diastolic area. And this is called the fractional area change, which is put as FAC in the echo report. And normal value is going to be between 40 to 60%. So you can measure the ejection fraction, you can look at fractional shortening, and you can look at fractional area change. Volume, diameter, and area. You measure at end systole and end diastole, and you get the values. And another important thing is measurement of each chamber. If you place the M mode, as I said earlier, you place the M mode cursor here, you get the right ventricle dimension, Then this is the septum. This is the septal dimension. This is the left ventricle. You can see the arrow mark. This is the left ventricle. This is the left ventricle dimension and the posterior wall. What is very important is you take the measurement in diastole and as well as in systole. You measure in diastole and systole, the same measurements, okay? You measure the thickness of the right ventricle, interventricular septum, left ventricle and the posterior wall. And as I said, if you place a cursor across the aortic wall and left atrium, you get the aortic LA ratio, which is very, very important. Why you have to measure this? This aortic diameter is usually fixed and it won't change much with your volume changes. But LA diameter can change with your left ventricle compliance or your mitral stenosis or your volume loading, everything, your LA diameter will change. So it is dynamic. Here you can see this is aortic value and this is the LA value. They measure the both. But what happens is the normal aortic LA ratio is 1:1. Here you can see the aortic diameter is so little, but the LA diameter is so much enlarged. That means your LA is, here the LA ratio, LA diameter is around 4.5 and the LA is more than the aorta. That means the LA, some problem with the left ventricle or LA dimension has happened and LA is struggling. It is very, very important to assess the LA diameter, particularly in a left side lesion. Then in a nice 4-chamber view from the apical view, you can see all the dimension. You can measure the right atrial transfer diameter as well as the longitudinal diameter. Like that you can do for all the 4 chambers. You can measure the LA size, RA size, left ventricle and the right ventricle. And normally you have to see that left ventricle is slightly bigger than the right ventricle. The right ventricle is 2/3 of the left ventricle. Another important terminology which we see in the echocardiogram is concentric hypertrophy. Okay, here you have a normal LV. The LV can undergo a concentric left ventricle modeling, concentric LV remodeling, or it undergoes a concentric left ventricle hypertrophy, or it can undergo an eccentric hypertrophy. How do you get this terminology with echocardiogram? For that, you have to measure the septal thickness, your internal diameter of the left ventricle and the posterior wall thickness. Okay, here you can see two terminology, left ventricular mass index and regional wall thickness. With this two variables only, we can know whether it is remodeling or undergoing a hypertrophy or undergoing an eccentric hypertrophy. So you measure this diameter in the left ventricular dimension in diastole, your septum and your posterior wall. And if you put a complex formula, you get what is called the left ventricular mass index. It is normally greater than 115 gram per meter square in male. In females, it is going to be roughly around 105 grams per meter square. And for calculating the relative wall thickness, it is going to be only the posterior wall diameter, posterior wall thickness and the left ventricular internal diameter. And you calculate the relative wall thickness. So with this, how you know it is concentric or eccentric hypertrophy? If it is concentric, your regional wall thickness is greater than 0.42. If it is eccentric, it is less than 0.42. So you know whether it is concentric hypertrophy or eccentric hypertrophy. Eccentric hypertrophy are really difficult to treat. Usually what we do, we just say concentric hypertrophy and leave it. We don't know how much the concentric hypertrophy is there. If you look here, you will understand the importance of concentric hypertrophy. Here you can see the LV is hypertrophied and hardly any left ventricular cavity is there. In this case, if you reduce the afterload or by giving a spinal or causing a sympathectomy, your entire left ventricular cavity will be obliterated. If you reduce the afterload, it will just close and there will be no outflow into the LVOT. So it is very, very important to maintain the afterload when you have a severe concentric hypertrophy like this. So now coming to the next important, let us analyze each echo report. The first thing which we are going to see is ejection fraction. Here you saw that ejection fraction is hardly 33%. So when the ejection fraction is very poor, you are going to look at what is called the end diastolic volume and end systolic volume. Here you can see the end diastolic volume, which is normally around 80 to 100, it has gone up to 150, almost double. And the systolic, which is roughly 40 to 60, has gone beyond 104. So there is hardly any contraction of the ventricle. The entire volume stays inside the left ventricle. There is global hypokinesia. Here it is the global movement. So here you can see this is the normal movement of the left ventricle, the slight reduction, and here the ventricle is hardly moving. And if you measure the dimension in systole and diastole, you can see the left ventricle cavity is so much enlarged. If you look here the dimension, left ventricular diameter at diastole is 7.1 and in systole it is 1.3. And you can see the ejection fraction is hardly 24% and the fractional shortening is 11%, which means the left ventricle contractile function is severely altered. Here you can see hardly any movement of the left ventricle wall. Here you can see ventricle is not moving great. So left ventricular ejection fraction it indicates the systolic function and it helps to predict your cardiovascular morbidity and mortality. It is mild systolic dysfunction when the ejection fraction is between 40 to 45%, moderate if it is between 35 to 40, and severe systolic dysfunction is when it is less than 35%. This is with regarding to ejection fraction. But certain things you should understand. Most important thing is it should be based on your patient clinical status and cardiac condition. Why it is like that? Even though it is 40 to 50 is abnormal, you think it is on the lesser side, but it has no clinical significance. You have to understand that. I will explain in the later slide why ejection fraction changes. See, for example, if you give the ejection fraction depends on the volume. If you alter your preload and afterload, your ejection fraction can alter. Suddenly, if you infuse a large amount of volume, your ejection fraction might increase. Similarly, in regurgitation, okay, ejection fraction will be overestimated because when heart ejects, it pumps blood will be there. One side blood will go and regurgitation fraction also will be there. So the ejection fraction will be overestimated. And what you have to do is whenever you take the ejection fraction, you have to subtract the regurgitation fraction from that actual ejection fraction to get the real ejection fraction. Now coming to the next important thing. You looked at heart as a global entity to look at the systolic function, but you have to look at the regional walls. You have three major coronary vessels like left anterior descending, left circumflex and right coronary artery, and each supplies different wall of the right ventricle and the left ventricle. So if one particular artery is ischemic, that particular wall can undergo hypocontractile function. You can look at the regional walls to assess the adequacy of vascularity. So as you move from apex to base, you have about 17 walls. Okay, this is quite complex and it is good to have a knowledge of all the walls, but you have to understand 4 major walls of the ventricular cavity. And this parasternal view and the short axis view is very, very important to understand the regional wall motion contractility. Here, this is the short axis view. This is the lateral wall, septal wall, and this is the inferior wall, and this is the anterior wall. So at least this view, short axis view, you get the 4 major walls of the left ventricle. Here you can see the lateral wall is akinetic. The septum is not moving great, but the inferior wall is moving reasonably okay. Another important view is the parasternal long axis view, which I said you can see the right ventricle, you can see the septum, left ventricle, and the posterior wall. Here you can see the mitral valve, and here you can see the aortic valve. This 2 view is very, very important. Even if you are a non-cardiac anesthesiologist, this view is very, very important. And these 2 views, you should look for hyperkinesia, akinesia, or dyskinesia. And you can put a scoring system whether the wall is moving normally or not. Okay. Here you can see a nice 4-chamber view, and you can see all the valves are moving normally. This is a right ventricle, this is a left ventricle, this is a left atrium and right atrium. Here suddenly you can see this was a left anterior descending artery occlusion. Here you can see the apical part not moving, but the basal part is moving reasonably okay. This was a case of left anterior descending artery occlusion, and the anterior wall was not moving very well. Here you can see the apical part is not moving great. If you compare the motion, regional wall motion before and after, here you can see the apical wall moving reasonably nicely well, and here you can see the movement is altered. This is how one particular wall can be altered. So far we were looking about the systolic function. We looked systolic function as a global function as well as a regional function. Now look at the another important function, which is a diastolic function, which is a relaxation function of the heart, which we usually neglect. Here you can see grade 3 diastolic dysfunction. Whenever you have a diastolic dysfunction, next parameter which we look is the LA pressure. Here you can see the LA dimension is grossly enlarged. Here you can see an animal waiting to hunt its prey. Okay, see what is happening. It relaxes nicely, concentrates very hard, goes into hiding, and concentrate. You can see the concentration there. But this is the systolic function. Everybody looks at this part, systolic part, but amount of concentration with relaxation which is required is the diastole. We tend to ignore the relaxation part. You have to remember that diastole is the energy consuming process of the cardiac cycle, not the systole. So you have to concentrate more important on diastole also. So coming to diastolic dysfunction, it usually precedes left ventricular systolic dysfunction. And whenever systolic dysfunction exists, there is a very high chance that your diastolic function is also abnormal. And irrespective of systolic function, whenever diastolic dysfunction is there, it is a predictor for all-cause mortality. And sometime in 1/3 of the patient with heart failure, they might have only diastolic dysfunction. Systolic might be normal. They might have diastolic dysfunction alone. And the common etiology is going to be an elderly patient, your hypertension and myocardial ischemia. These are all common, which you can see after 60 years of age. So how you are going to assess your diastolic function? You place the Doppler probe across the mitral valve to get the transmitral flow, or across the pulmonary vein to see the pulmonary venous inflow, or you can measure Doppler tissue velocity across the mitral valve or transmitral flow propagation velocity. Let us look at this two, placing the probe across the mitral valve and the pulmonary vein. Here, when you place the cursor across the mitral valve, you get two type of wave. One is called the E wave and another one is called the A wave. A wave is due to atrial contraction and E wave is due to isovolumetric relaxation. Normally, E will be taller than the A. With the height of the A wave and the characteristic of the E and A wave, you can get various form of diastolic dysfunction. Various stages of diastolic dysfunction is characterized with this, classified based on the characteristics of this wave. Then you place the cursor across the pulmonary vein and you get two systolic wave, one diastolic wave and a atrial reversal wave. Here you have two systolic wave, one diastolic wave and a atrial reversal wave. So based on this waveform, here you can see the EA wave and here you can see the systolic, diastolic and atrial reversal wave. So as your diastolic function progress from mild to moderate to severe, each waveform will have, each stage will have particular form of a waveform. But what is very, very important is as you progress from mild, moderate to severe, your LV relaxation comes down, your compliance is affected, and most important thing is your LA pressure is progressively increasing. This is your diastolic dysfunction with regard to echo.
Ranjit,
So
3
far
more
we are
minutes.
looking only about the left
Ranjit,
ventricle.
3 more
We
minutes.
forgot what is right ventricle. Take it from me, treating left ventricle, you have many options, but right ventricle, your pharmacology will be tested and you have to be very, very careful with your ventilation when treating right ventricle. And whenever you look at right ventricle, you see this pulmonary artery hypertension. Okay, right ventricle does not tolerate pressure. Okay, you have to take it that in mind. Whenever whatever anesthetic maneuver you do, if you mechanically ventilate, your pulmonary artery pressure goes up, and in a slightly labile Harvey function, this mechanical ventilation will make the mild dysfunction into moderate RV dysfunction. So we should be very, very careful in altering the pulmonary artery pressure. Normally, the right ventricle is 2/3 of the size of the left ventricle. This is the left ventricle and this is the right ventricle.
Ranjit, sorry to interrupt. Ranjit, 3 more minutes. Sorry to interrupt.
But it may not be the size of left ventricle. It is from 2/3, it might have increased to 70 to 80% of the size of the left ventricle. Then it is mild RV dysfunction. When it equals the size of left ventricle, it is moderate LV dysfunction. And when it pushes the septum towards the left ventricle. Compromising the left ventricle, also it is severe right ventricle dysfunction. A simple eyeballing to say whether right ventricle is normal or not. Here you can see the septum moving towards the left ventricle. That means your right ventricle is enlarged and pushes the septum. That means the patient has already gone into severe right ventricle dysfunction. And another important measurement for assessing right ventricle is tricuspid annular presystolic exertion. Here you place the cursor across the lateral annulus of the tricuspid valve and you measure the what is called the TAPC. In normal RV function, the TAPC will be greater than 16 millimeter. If it is less than 16 millimeter, that means your RV function is inadequate. And like you measure the fractional family. So this is the main low. Your CVP is low. Calculate your pulmonary 40, it is moderate. It is greater than 50, it is severe pulmonary artery hypertension. And if it is greater than 60, it is suprasystemic pulmonary artery pressure. So far we are looking about left ventricle, systole, diastole, and we looked at the right ventricle. So in the heart fails, what happened? It is going to cause back pressure on the venous system and your IVC is going to be dilated. So if you look at the subcostal view, you can measure the IVC diameter. If the IVC diameter is dilated, that means your volume status, the patient is in a state of hypervolemia. Here you can see the IVC diameter, it is very high and it is not collapsible. Here you can see the dilated IVC. So this is the dilated IVC not collapsing with inspiration, and this is the normal IVC which collapses with inspiration with the positive pressure ventilation. So this is the volume. This is while coming off in a cardiopulmonary bypass. The heart which was empty. Here you can see heart is empty. And as you fill more and more volume, you can see the left ventricle cavity is increasing. Okay, you can see the size of the left ventricle slowly increasing. If you look here, this is small, this is almost twice the size. If you measure the ejection fraction, this will be different. If you measure the ejection fraction here, it will be different. So it is very, very important to fill the left ventricle
Ranjit,
compromised.
Ranjit, we must have some time for discussion also.
Your IVC.
Another 2 minutes.
Okay.
yeah, you have your video says 40 minutes.
No, sir. I will
2.1. And there is greater than 50% collapse. That means your right atrial pressure is very low. Your CVP is low. Your IVC diameter is less than 2.1, but the collapse is not there. That means your RA pressure is going to be on the higher side of the normal. Your IVC diameter is high, but collapse is greater than 50%. That means it is again around 8. There is increase in IVC diameter and no collapsibility of IVC diameter. That means your CVP is really high. This is how you get your right atrial pressure from your IVC diameter. Now coming to the most important part. The heart has 4 chambers, we know that. So each chamber is separated by 4 different valves. That is the aortic, mitral, tricuspid and your pulmonary valve. These 4 valves are like a nice, beautiful family. Okay, your aortic valve is like the father. The entire cardiac output of the left ventricle goes out through the aortic valve. So this is the face of all the valves. It is like the face of the family. Your father represents the family. So this is the main valve. Even though all the valve works normally, everything has to go through him only. And your mother is like the mitral valve. It takes the stress of the right ventricle and the left ventricle, and if it is abnormal, both are going to be affected. So this is the backbone of all the valves. And your tricuspid valve is like your son. Either they bring joy or sorrow to the family. This is the main source of problem actually. And your pulmonary valve is like your daughter. Usually they never give trouble. But if they give trouble, it is definitely very, very difficult to fix it. That is the family of nice 4 valves. So whenever you have a stenosis, your diastolic dysfunction, it is diastolic function, it is graded ventricular function, ventricle. And it will be very catastrophic unless you release it. To summarize your echo report, the first and foremost is you have to look at the date. Whether this report reflect the patient clinical current status. You have to have a clinical picture before doing a echocardiogram. Don't just look at the echocardiogram and then look at the patient. You have to look at the patient and then look at the echocardiogram. That is very, very important. Then you have to answer why you ask for an echocardiogram, whether the patient cardiac status warrants echocardiogram. And third thing you have to look at is your rate and rhythm, whether the rhythm is altered or it is affecting your ventricular function. Next, rhythm abnormality. And you have to understand we are doing multiple abnormalities, just leading because about them, and not to forget the structures outside the heart like pericardium, pleura, and if there is any mass, and also look at the aorta. Aorta also might be, you should look at the aorta also because aorta might lead to a lot of hemodynamic disturbances. Okay, coming to the conclusion. Look at the red lines, okay? Everything, this 54, 30, 82, 44, what are those things? These are the percentage of changes which happen with the knowledge of echocardiogram in the perioperative period. Anesthesiologist who had knowledge about echocardiogram, the hemodynamic and anesthetic management changed in more than 50 to 70% of the changes. And you have to understand this point. There is a greater impact in those with hemodynamic instability. So your echocardiogram will definitely come in handy. Your echocardiographic knowledge will come in handy whenever there is hemodynamic instability is there. And most important thing is it is helpful in all cases. And you can see there is almost 50% changes in drug therapy, and your fluid therapy is also altered because you know the volume status. And overall, there is 33% change in anesthesia and hemodynamic changes with your echocardiogram. So it is imperative whether you are a general anesthetist or cardiac anesthetist, your knowledge about echocardiogram should be very thorough. So when you hear like this, you forget. When you see like this, you may remember. But with echocardiogram, unless you do, please everybody learn echocardiogram. Thank you.
Thank you, Ranjit. Even though you have overstood the time, excellent presentation, Ranjit. Over to Kumar and Guru.
Yeah, almost 15 minutes, 10 minutes more.
Yeah, okay. Thank you, Ranjit, for an excellent, very elaborate talk and very informative talk.
Yes. Sorry, Kumar. Sorry for exceeding.
No issues. No, it's already informed yesterday itself, but slightly gone up, no problem. But it is very useful, definitely very useful. Very few questions from the audience.
Kumar, time another 5 minutes.
Yeah, 5 minutes will finish up quickly, sir. About the diastolic dysfunction and its significance in the periop.
Yeah, you have to avoid the heart rate. Heart rate going up is very, very dangerous for diastolic dysfunction. And you should see that pulse pressure is not more than the diastolic pressure. These two things you have to take very, very much care when you have a diastolic dysfunction.
Okay, good. Usually in diastolic dysfunction, the heart rate is going up and the compliance is low, and the possibility for periop pulmonary edema is very common in non-cardiac settings.
Most important thing is you have to maintain the sinus rhythm. You should have a low threshold for cardioversion if patient goes into arrhythmia. If arrhythmia sets in with the diastolic dysfunction, you get into trouble. Definitely you will get into trouble.
Okay. Then one more question about fractional shortening and its significance.
Yeah, mainly to overcome the clinical insignificance, mainly to overcome the shortcomings of ejection fraction, fractional shortening and FAC should be used. You should know
because everyone looking at ejection fraction alone, and you are telling about fraction.
The echo report with FS and FAC.
Yeah, definitely.
That is what I want to highlight. It is very important. It is a more reliable marker for contractile function than ejection fraction. You have to understand that.
Yes. And then how to say that it is concentric hypertrophy or eccentric hypertrophy? Already elaborated.
Yeah, that regional wall index you have to see, no? Regional wall thickness.
Regional wall thickness. As per the regional wall thickness, you have to differentiate. Is there any ways to grade that hypertrophy? Concentric hypertrophy, mild or severe? Is there any entity like that?
The ratio we can do it. That ratio, each ratio is there. With that ratio, you can go in for mild to severe concentric hypertrophy. I don't know the exact range of the ratio, but definitely with that ratio, regional wall thickness ratio, you can calculate the concentric hypertrophy.
And one more question about paradoxical septum and its significance in the periop.
Paradoxical septum usually.
Paradoxical IBS. Yeah, IBS.
Yeah, right ventricular dysfunction. Usually when you go for mechanical ventilation, you are bound to injure right ventricle a little bit. And when right ventricle is on the margin of suffering or some PA pressures are high, this will move to the other side. Then both your left and the right will be compromised. Already right will be compromised by your paradoxical septal motion. Your left ventricle also gets compromised. So what was a single ventricle now becomes a biventricular dysfunction, and it becomes very difficult to treat.
Yeah, it clearly indicates RV dysfunction. Later it can produce LV dysfunction also. So that is the message. And then last question about GLS and its significance. Global longitudinal strain.
I have not much experience with the strain image.
I do I use a lot of GLS. Definitely, whenever we have doubt about the ejection fraction, GLS nowadays is used very much in clinical practice to assess the contractility of the segments, particularly in each segments, how much the GLS is there. As per that, we can assess the exact regional wall motion abnormality and exact myocardial function. So that is the current status of LV functional assessment. GLS is very useful in clinical practice nowadays. We are using routinely during pre-op as well as in the intra-op also during the procedures. So global longitudinal strain is more useful than the conventional ejection fraction measurements to assess the myocardial function in the perioperative state.
Okay. But
the normal values are usually above 17, and if it is less than 15, it is considered to be significant.
Okay.
The GLS values more than 17 are considered to be normal, and if it is less than 17 or less than 15, it is considered to be LV dysfunction.
But so I have to thank all the non-cardiac anesthetists. See, being a
that's why I don't want to go too much into details.
Monitoring everything. But non-cardiac anesthetists with one NIBP, pulse ox, and ECG, anesthetizing a sick case. Hats off to all non-cardiac anesthetists.
No doubt.
But it's a knowledge everybody should learn. That is very, very important. That's what I want to stress. Hats off to all non-cardiac anesthetists.
No doubt. Definitely. With minimal gadgets, they are doing extremely good job with a lot of cases. Okay. I think we have come to the end of session. Is there any questions from the panel? Edward sir, Sudarshan sir?
No, I think we should be all right. We'll switch over to the next talk.
Okay. If there are no further questions, we'll conclude the session. I thank Dr. Ranjit for the nice talk and excellent discussion. We'll move on to the next talk. I hand over my e-mic to my co-moderator, Dr. Gurumurthy sir. Gurumurthy sir, please.
Good morning, sir. Am I audible?
Yeah, well audible, sir.
So, good morning, everyone. So, I am happy to introduce Professor G.K. Kumar, MD, FIPP, a good friend of mine. And also, not only a friend, he began most of the youngsters like us to pursue pain management. So he began almost most of the pain physicians who are practicing in Tamil Nadu. He is a well-known person, and he guides us in a lot. We are happy to introduce him as the president of ISSP, that is the Indian Society of Study of Pain, Tamil Nadu chapter. And sir is currently holding the professor of anesthesiology in Government Chengalpattu Medical College. We feel proud that he is the first professor and in charge for the Chronic Pain Management Center started in a government setup, that is in MMC. So he is well known as a pain physician and also as an anesthesiologist. So he is the ideal person to talk on chronic, especially the post-op pain management. I welcome sir, and I will hand over that mic to sir. Thank you.
Hello, good afternoon to you all. It's a great pleasure for me to see all of my teachers. It's a nice blend of gathering which consists of my mentors like Balakrishnan sir and my teachers like Ganesh Prabhu sir and my colleagues and my students also there. Shall I share my screen? And outside, I have to thank the. Can you see my screen?
Yes.
Yeah, I have to thank the city branch, ISA city branch Chennai, as well as the ISA state branch for giving the excellent opportunity, and as a highly honored being to sit in front of you. And the ISA city branch, I am closely associated to 2 branches. Madurai is my born place and Chennai is my settled place. So I have a lot of friends in 2 city branches, not only there and everywhere. Thanks a lot. And coming to the topic per se, the post-operative pain, current understanding and management. So current postoperative pain. So what we have done so far, management of the postoperative pain. This is my one of the oldest slide. I have taken unmodified with the same presentation. See, this is one of the strange study conducted in two different years, 2003 and 1995. They conducted a telephonic conversation of the around 20,000 patients across the Europe to know about what is the concern before they are coming for surgery. So the main problem was concerned about the pain. That is also pain after the surgery. So 59% of the patients who interviewed in 2003 by Applebaum have highly raised the concern about the pain, especially the post-operative pain. And during the surgery also they are concerned, but we concentrate only here. That is the post-operative pain is the 59%. This is nothing but the exactly same. The study was conducted almost 10 years before by Warfield et al. The same 57% is quite amazing there. But coming to now, what we are doing, again, I had two studies, which is 2011 and 2020. This is by Srinivasa and Raja, is a known person in IASP. And 2020, the British Journal of Society of Surgery. So it's quite, we have to see the surgeon's perspective also that. Let's see what's happening. This is actual study. The Netherlands study, the UK, that is another in Europe, 41% of the patients had moderate pain and 15% of have severe pain and the post-operative, fourth post-operative day. This is the USA. In 1 in 4 surgical, almost 25% of the patient has considerable pain. And this is the in 2020, again 48% reported moderate and 90% severe in first post-operative. Maybe the first post-operative a little bit higher incidence. Another study conducted in Germany, again they have the 47% of pain. So whatever may be that for the past decades, both the decades 2011 to 10, the almost same incidents we are facing that. Why? Why we are taking a lot of improvement, lot of developments in things? Why we are having the same kind of the statistics throughout the decades? Again, they had one among now that is for the patient perspective. Now they have the surgeon's perspective. That is around 501 patients and physicians, mostly surgeons. They concern about, they want to have that. The top unmet need is the moderate to severe post-operative handling. And they want to have the one drug or something to have that without any side effect. They are their concerns. Mostly they follow the IV analgesia, either the opioid or the NSAID or the combination of the three. So still we are the challenge. What are the challenges against the management of the post-operative pain? Causes are multifactorial. Because the continued paucity of the pain assessment and documentation, unless you assess the pain and unless you document the pain, you will never accept the patient is having pain. The absence of specific protocols, post-operative, especially in post-operative area is there. This is the standard protocol. We are having that. We are making ourselves on tailor-made protocol. Then we are trying to make every patient to be satisfied with our protocol. We are not modifying the protocols. Actually, we are modifying the patients to fit into our protocols. So continuous deficiency of the education of the pain management programs. Not only the healthcare workers, but also those who are managing the patients, especially the staff nurses and paramedicals. Underuse of the effective analgesic techniques. A lot of techniques are there, but due to various circumstances, cost-effective, awareness about the things, and post-operative management facilities, all influences us to make underuse of the effective available analgesic techniques and poor adherence to the available guidelines. We never will modify ourselves, we'll make it comfortable ourselves to change the guidelines, and we never bother about or will neglect completely, conveniently what is happening towards the patient's satisfaction. So the key points for another 10 to 15 minutes, what is the post-operative pain mechanism and identification of the post-operative pain, and framing the more effective and safer clinical strategy to management of the post-operative pain. And the most controversial or not accepted in universe is the preemptive analgesia, and few words about the preventive analgesia and recent options and future developments we are going to face it. So coming to the postoperative pain mechanism, why we have to study about the postoperative pain mechanism? Because the postoperative pain mechanism is entirely different from our inflammatory pain mechanism. So it is not simple as it's projected. It is because it's oversimplified all the times, but a lot of things are happening inside the postoperative pain mechanism. That's why we are failing miserably sometimes handling the postoperative pain. Unless we know these things, it is very difficult to manage effectively. So this is simple one, normal pain processing pathway. This is the stimulus sensed by the peripheral nerves, and it is conducted towards the DRG, and the posterior column is dorsal root ganglion and dorsal column, and it is ascended upwards through the ascending tract, and the pain is pursued, and it has central signaling modifications, and sometimes it will enhances the, sometimes it will decreases the pain signals, sometimes it enhances the pain signal also. That is depend upon the genetic makeup of the patients. Don't think all the time the descending pathway will reduce the pain. The most important thing is the what we know is the glutamyl and substance P is making important mediators happening here, and they are the most responsible for that conduction of the pain through that. But this is not the simple thing happening when the post-incisional pain. The simple thing is that this is called transduction and transmission and perception. But this modulation is happening here. It is happening here, here, and here. These are all called peripheral centralization. This is called sensitization. This is called and central sensitization. This is the most important thing. What we have thought previously happening only in long-term pain, but now it has swiftly happens. That's why the sensitization process are not exclusively for the chronic pain. It occurs along with that any acute pain changes. So what we have to do that we have to target along the pain pathways to handle this kind of the pains. So here, here, and here, and here, and here. This is called where multimodal anesthesia. This is the most important thing whenever you want to know about the post-operative pain management. Simple, this word will call multimodal analgesia. Multimodal analgesia effective. What do you mean by the multimodal analgesia? Targeting different sites with the different agents through different modalities and techniques. This is the most important thing. When you have the multiple option is there, definitely we will get confused. That is the problem. There is no standard protocol of this one and this one for this kind of the post-operative pain. And we don't have that because of the lot of variability among the surgical stimulus, and lot of variability among the patient response, a lot of variability among the agents, lot of variability among the doses, lot of variability among the techniques, all the matters. That's why each study will produce different kind of the effect to us and making us great confusion. And we finally settle down with the most easiest one is the intravenous and simple regional techniques. So what is happening in the post-operative pain mechanism? Unless you know them effectively, this is very difficult. I have taken the few points from these two studies. It's worth reading again that, even though it is the older one you're thinking, but it has the recent one. It is not the older one. It's taken from the recent one. The essence of that is the clinical studies, the rodent models. There are a lot of the models are there to know about the animal models are there to know about the post-operative pain. It indicates the primary afferent nociception is the nociceptor and dorsal horn are the prime site. But not only the simply happening that it produces the resting pain, hyperalgesia, and movement evoked pain, and some psychological modifications. All four factors are contributed through these sites. So how it is happening that through that certain receptors, not only the single receptors, lot of mediators and neurotransmitters also there. Many of these are very specific and unique for incisional pain. It is not simply inflammatory process or a neuropathic process. It's a fine blend of both the things. And apart from that, genetic factors plays a major role, and sometimes it will contribute us to in future to handle the post-operative pain. So what do you mean by the peripheral sensitization? Sensitization is nothing but the abnormal reactivity to the normal stimulus, or there is no stimulus. When it is happening in the peripheral nervous system, it is called peripheral sensitization. This is the most important thing we have to look for, and we have to target these things. So how the peripheral sensitization occurs? Not only the simple nociception. The spontaneous activity, the nociceptors are stimulated after the incision. That is called even after the external stimuli. Once the patient getting insight, there is the spontaneous activity, the nociceptors from the skin as well as the deep muscles also. They are that one way the commonly the persistent signaling is sending through the site, and it is sending by chemical sensitization also. That means even after that incision, there is the in that site particularly ischemic mediators are there, particularly lactic acids. Some immunocytochemistry reveals the ischemic mediators are sensitizing that, they're stimulating the nerve ending and receptors more. This is the reason for spontaneous activity may be there and persistent activity will be there. And one more type is there, the expression of the TRVP, vanillite receptor 1, that will sensitize the C fibers. That is the reason where some kind of capsaicin is plays the role. That is the specifically blocking these receptors. So again, not only these things, the energy, nerve growth factors, the artemin, also contributing towards the pain sensitization. And our well-known interleukins are there. And we have that interleukin L1 is the prime impact. Also, nowadays it has the IL-6, which is well known now in pandemic areas. Also, we can do a lot of now everywhere is the RT-PCR is available. We have the conduct the studies more. All the hospitals will have the RT-PCR when there is a possibility to do that. IL-6 also we can do that. And IL-6 estimation is also there. And the complementary proteins also will increase that. These are a little bit known to us, but the unknown factor is these are all things. So once you are giving the anti-inflammatory drugs, you are expecting the patient to have settled down with this is not possible, because lot of ways the patient is getting stimulated spontaneous activity through the ischemic case. Unless you increase the blood flow, that post of the ischemic mediators, the patient have this persistent thing. So if you're taking care of the one part and you are neglecting others, definitely our poor patients will not have the 100% or near normal or satisfactory pain relief. That so the peripheral sensitization have the lot of roots to grow. That is the one thing you have to keep in mind. Then how it's again the central sensitization. The peripheral sensitization itself the stimulus for the central sensitization. The dorsal horn neuronal activity after incision is very much increased. That will increase, keep on sending the signals to the higher areas, that is the pain is perceived. And the NMDA receptors are most common thing is happening in the dorsal horn neural area, whereas the non-NMDA receptors, the excitatory amino acids are also responsible for the central sensitization. So all together, I'll come to the small, just a minute. One small animation of that. So can you see the screen again?
Yes.
Okay, fine. Thank you. Okay, this is the thing, normal thing. I already told that, but this is the thing. So when the normally getting small incision that we have, this is the normal, what we are thinking that it happening, that sending signals are through the ascending thing, and the pain is perceived, and descending, and it will modulates, and it reduces the pain. Mostly, sometimes it will aggravate the pain. This is the thing, simple, basic pain pathway, but it is not simple one, because the sensitization is a problem here. How it occurs? Sensitization is nothing but the amplification of the pain signal. It occurs two ways, or two areas, peripheral as well as the central. How does it occur? One, when there is an incision is there, minimal stimuli releases a lot of pain neurotransmitters, that is glutamate and substance V. That's obviously increased pain occurs, that is called pain signals occurs, that is called pain amplification in the peripheral area, that is called peripheral sensitization. But this is the reason for that pronounced pain perception in the brain area, that is called for the central sensitization. The descending pain, instead of descending signals, instead of controlling the pain, reducing the pain, it will stimulate itself. That's why the cycle goes of vicious and increased pain perception. So now you understand the problem of incisional pain. One more minute, I'll come to my regular one. Can you able to see that?
Yes. Yes.
Okay. So what is the solution? This much of the complicated issues are behind us. So what is the solution? The solution is acute pain services. What do you mean by the acute pain service? This is a small study in ASEAN, Korean study. Will have the acute pain services should be there, dedicated exclusively there should be there. They trained the nurses in their hospital, and they compared with the trained one, untrained one, because but the trained one, they have the excellent increase in the post-operative pain score. I mean, patient satisfaction very high. That means simple acute pain services protocols will definitely improve rather than the complicated gadgets and other things. What are the things we can take out from the studies? Nothing but we have to formulate 1 hour protocol. Mostly it may be the experience based, need not be the evidence based, but it should be evolved through the evidence based later. Unless you start acute pain services, which is dedicated and exclusively, we are not able to find out the post-operative pain, identification of the post-operative pain, and subsequent management of the post-operative pain. So there is a lot of clinical practical guideline is there, but these guidelines are always this is the one guideline 2016 they released 34 recommendations. So among the 34 recommendations, few are highly recommended with good evidences, strong evidences. What are the evidences then? Again, they are telling us the multimodal technique, you have to follow that. Simply this recommends the multimodal technique. Among the multimodal technique, what are the things? The regional anesthetic techniques major role with parenteral analgesics, whatever may be there, but they have to instill, you have to look for that a possible inclusion of the regional anesthesia. And regional anesthesia doesn't require the epidural alone. It concentrates on the peripheral nerve block, and apart from that, incisional site infiltration. This nowadays gaining popular, that is called wound infiltration techniques. So it right from the wound infiltration technique towards the central neuroaxial blockade, you have to select any one of the things to suit to your patients, and you have to suit any one of the available parenteral or any adjuvants for satisfying the patients or taking care of the pain. Apart from that, it recommends very highly, even though there is evidences are low with that, you have to keep on educating the patients pre-operatively and share his, and you have to know that what is perception towards the pain, and all the things to be pre-anesthetic evaluation and education of the patients also highly recommended, even though the evidences are not much encouraging. So with these things, again, coming back to the multimodal, what does it mean? It's a technique, not simple techniques, is a different kind of the techniques using different kind of the modalities, and you have used the different kind of the drugs, especially in adjuvants to your local anesthetics or IV agents and different modes of administration. And apart from that, what you have to do that, observe the outcome of the patient and you have to modify or supplement. Unless you observe the last step, all the things will lead to your bias, the things that your technique is supreme to everything. So the multimodal, where the drug is acting, the peripheral sensitization and central sensitization, these are all the known drug which is coming, the local anesthetics and topical agents, anticonvulsants, tricyclic antidepressant, opioids, and these things are known to us. And we have the different kind of the local anesthetics and different kind of the topical analgesics, also the especially the capsaicin, and anticonvulsants also have the greater role. And the NMDA receptor antagonists, the known ketamine and dexmedetomidine, and alpha 2 agonists also there, especially the dexmedetomidine. All the things are nowadays getting popularity. And the descending thing, again, coming to the tricyclic antidepressants, and all the things are there apart from your regional anesthetic techniques. So in general, what multimodal things, this is the solution for that. But what is the reality? These are the current issues in the post-operative management. The Rowell et al., European Journal of Anesthesia, released 2016. But the reality in general, research to the multimodal anesthesia has not shown the consistent level of success because the large number of the variables in available studies. This include the variety. We have the plenty of analgesics, plenty of the adjuvants and modalities, route of administration, method of administration, and makes it difficult to draw the relevant or concrete evidences to adopt one particular regimen or technique. That is the greatest problem of multimodal. So what should be in your cocktail to manage the patient? So we have the lot of, there is no single drug will produce the effective magic bullet for handling the pain. The concurrent use of more than one class of analgesics or techniques to target the different mechanism has been advocated to improve the analgesia through the additive or synergistic effects. There is no universal formula. There is a 1 + 1 is, and it will be always 2 for your patients. Not there is no like that. So only the options are there. For that, you should understand the mechanism behind the post-operative pain and what are the drug receptors are acting through that. And based on your things, you have to take the final call by you only. So what are the options we have? The adjuvants, with the local, suppose you are doing with the regional anesthesia, you can add local anesthetics with opioids. Alpha 2 adrenal receptor agonists are there. Vasoconstrictors, the most common one is the adrenaline. How the adrenaline is useful for longer acting? It has the inherent property of alpha 2 receptor action. So that is also a little bit nociceptive. That is the explanation given when it is used along with drug like bupivacaine. And dexamethasone is the one very promising effect when they know this is going to used with the peripheral nerves, especially the upper limb blockage. Last week we had a very good lecture through the Kerala ISA webcon. There's the Vincent Chance has promoted this one and recommended very highly for especially the this is the most useful, effective tool for prolonging the post-op analgesia when we are, especially for the upper limb blockade. And sodium bicarbonate is again one more thing is which is mainly used for rapid onset. And I see that the sodium we have a lot of course we have fortunately I am what to say that surprisingly the dental local anesthetic techniques and gadgets improved a lot. They have the sodium bicarbonate loader cartridge for exclusively for making the onset very rapidly, and they have a lot of tools to give the local anesthesia for their procedures. And we have that NMDA blockers, that is ketamine and midazolam, neostigmine. The most recent one is the adenosine and dextron. The adenosine is still studies are going on, but it is promising results are there, but it has to be conducted in human studies. Dextron is the another one, which is also finding very helpful. So this is the nutshell. And what are these are opioids in general. The gold standard always the morphine. Morphine is still one of the good drug which you can give it in all format: intrathecal, epidural, peripheral nerve blocks, and now it is coming the intranasal, and so many things are there with a lot of carriers with the epidural exclusively for longer acting drugs are coming. So people are wondering about why the morphine is already long acting. Why we have to have that liposomal carrier morphine, which is needed. This is thing, single drug, single deposition. When there is a problem with the patient with anticoagulant, we will give the single dose and it will have the prolonged effect. That kind of the patient, definitely the longer acting drugs are going to be useful. The common complications and not recommended. Not much useful for peripheral nerve blocks, because it is again it takes the systemic effect. That is why it's not much useful. But these are all things already used. And fentanyl, again, the most common intrathecal used one. And peripheral nerve blocks, not much useful. And the sufentanil is a very short period. It is introduced in India and taken back, and it is very much useful when given intrathecal things. And hydromorphine, especially useful for patient with a renal problem. And buprenorphine, again, was used to so many people by that, because of the problematic of the fear of respiratory, non-reversible respiratory depression, and approval rate is very severe. That's why almost it is stopped. Now it is coming as patches. And I think tramadol, again, is widely used, but it is not much in prolonged effect we are anticipated, but it may be the something is better than nothing, because it has the lot of much side effects, especially the nausea and vomiting is very much pronounced. So the next thing is coming to alpha 2 agonists, that these two drugs are there. The clonidine is the golden drug which has given exclusively lot of study was there. The clonidine, especially in pediatric age group and caudal thing. The most important thing is side effect of the bradycardia and the sedation. When you are using the less than around 1 mg per kg, the complication is very much less. But bradycardia and other things are very common, especially in older individuals. And dexmedetomidine nowadays are replacing that clonidine, and it is also given everywhere, and this is found to be effective mechanisms through the junctional alpha 2, similar to the clonidine. And the other drugs, dexamethasone, among the drugs, the most promising and number one place is dexamethasone, and usually it is given 4 to 8 gram, and it's prolonged the nerve block in peripheral nerve blocks. It is the most important thing, especially in the upper limb blockade. It is not showing lower limb blockade, promising results. The reason is unknown, but right now it is the most promising for upper limb blockade. The midazolam again has given a lot of routes there, and this thing not recommended for the routine neuraxial and peripheral nerve tools, because it produces a very heavy sedation. I mean, even though it is a limited usage, even though it is used in lesser doses. And neostigmine, again, the post-operative nausea or vomiting is very high, so it is not much recommended. Ketamine, neuraxial is thing short duration anesthesia, and it is used for parenteral rather than the along with the nerve block or neuraxial area. So magnesium, again, the promising is that the problem is the headache and nausea, vomiting, and it prolongs the analgesia and by through the NMDA receptor antagonism, altered calcium channel blockade, but not recommended for the routine usage. So coming back to, these are all the things which we have already. What are the future we have that looking for the newer developments? The butyl aminobenzoate ester is one of the local anesthetic which has the very high duration of the pain relief up to 14 weeks. It's a quite longer time through the blockade of the persistent blockade of the sodium channel and the but it is a one of the promising things which are the single drug which may take care of the most of the pains. And charged molecules that tourniquet, another thing which is very much used in dental practice and other things, which have the long duration of the pain and rapid onset is there. This is because of the charged molecule, and the butyl tetracaine also promising results are there. And the newer age delivery mechanisms such as liposomal vehicles and microspheres and cyclodextrins are there. Already the liposomal lipoproteins are there for two things. One is the local anesthetic as well as the morphine. But their toxicity and other things are yet to be studied, and it is briefly introduced and again taken back due to some of the complications. The most another promising drug is the adenosine, which has the initial promise because of some mediated spinal adenosine receptors, but it requires for the clarification of the neurotoxicity. And dextrose, again, which is used for water soluble making, is a pH favorable term, something like sodium bicarbonate. It is also prolongs the action. For that, it's also required a lot of study. That neuromuscular blocking drugs are already done, but we have the little bit concern right now. It is restricted only the periverbal blocks and intravenous regional anesthesia, not for all cases. So these are all things you have to take in very, very, very careful when you are choosing the drug like that without any experience or evidence. So the promising neuro development is the patient control analgesia. What we know is patient control analgesia through the IV, through the parenteral, through the neuraxial, all the things we have know that. Now the newer things are patient control anesthesia, transpermanently analgesia. This is the Aerolef. This is a specific fentanyl which has the Aerolef, but we have to have that lot of studies has to be come up with encouraging these things. They're still in experimental stages, but it's a promising one. We have to just give that pure puff, something like that. The patient will have the good pain relief. It will be there. The intranasal patient control intranasal analgesia is the another promising one. It has the powder or liquid which is delivered through the syringes or dispersing devices, which is very easy to do that. These are all the needleless technique, and doesn't require any kind of the technique. I mean, interventions or something like placing your catheter or producing the block under ultrasound, and makes the job a little bit easier, but we have to wait for a little bit long time. The most promising one is the transdermal patient control analgesia. The inotropic effect is that the battery operated that is a small energy is delivered through the stimulate the reservoir in the skin, I mean the patch, and the drug is delivered through the dermis and other things, and it's something like that, the patches, but it's controlled by the delivery system. This is a promising one, but there is a lot of things happening here. That is the variability among the patient to patients make us to decide what is the exact dose is needed, and again it depends upon the underlying area has to be adequately perfused. Otherwise, this will not be useful. So it's a promising one. It looks simple, and this also requires a lot of studies and in coming days, and we can manifest. The newer developments, again, the aerosolized, liposomal, encapsulated fentanyl and morphine, the depot form particles, all the things are deposited in the epidural. We'd have the more than 48 to 72 hours action is there. And again, the most fearsome is the persistent action. We may have the respiratory depression, especially the drug which is already having the high half-life. So the other thing is the extended release epidural morphine, the Depo-Dur, and we have that fentanyl transcutaneous OTFC already is there, and this is the submucal buccal tablets are there. Already it is there for buprenorphine. Now it has come up with the fentanyl also there. So the most promising one is the genotype-based pain therapy, and this gives a lot of explanation why our patients are not satisfied particular drug, especially the preoperative in future when we are examining when we are case presentation for pre-anesthetic evaluation, we are never asked to forget the airway assessment. Sometimes in future, our postgraduate may present his genotype pattern also will be included in coming years for a pre-anesthetic evaluation, because this will help us to the patient will be find out the patient is sensitive to which drug, resistant to which drug, the patient going to have that complication to the which drug. For an example, this is the one thing which is the sodium gated channel, voltage gated channel, SCNNA. When you block this one, the patient will have the complete inability to sense the pain and identification and the pain, sense to pain that is there. So if you make this one reversible, and we have the chance of making the patient to have that pain-free for the required days. And the cytochrome, another cytochrome enzyme which requires for pro-drug activations. When you are giving the drug which is the pro-drug status, especially the codeine or paracetamol, this is the cytochrome makes it to be a actual active drug. When the patient's deficient with the drugs, then definitely the codeine and the pro-drugs are not going to be active. So again, the human mu receptor representations as called G variant varies to races to races. That's why some of the people are more sensitive to the opioids. Some of the people are more resistant to the opioids also there. Again, the same thing is the COX-2 gene is there, which will make us to responsible for the COX-2 inhibitors. That's why these are all the people already called as the prostaglandin responders. That's why this NSAID sometimes acts very nicely for some patients, but it won't do anything for some of the patients, because all these things based on their genetic makeup of their patients, individuals. That's why you cannot say that the one drug will, this NSAID you have given in correct dose also, the patient may not have the any kind of the pain relief, because they are not going to be have that there is a defective in PTGST2. Then another glycoprotein which is present in there, which will make very much vulnerable for the respiratory depression by the opioids. So yes sir,
still how much more time you have?
Okay sir, okay sir, almost I'm finished sir.
We're almost there.
So okay sir, so with this based on things, there's a lot of things are happening here in the genetic level. That's why in future these are all the way forward for us to handle the pain or avoid the complication of the pain, especially in post-operative status. So the most important, again, the most controversial is the preemptive analgesia. This is the one study which has conducted in the which has been in the 2016 released, that will give the good idea of the why the preemptive analgesia. A lot of variability among the preemptive analgesia results. Some people are saying it is excellent, some people are saying it is not useful. The idea why it is like that is because of the lot of mechanisms are playing in the perception of the pain and transmission of the pain and the amplification of the pain is there. That's why when you are giving one particular drug previously, and the patients fortunately responsible or response to that particular drug, they have the painful the post-op analgesia is responded. When unfortunately the patient is having that so some other mediators are predominantly there, definitely it will not be there. That's why the preemptive analgesia, the variability is there. Anyhow, the concept of preemptive analgesia was based on the hypothesis that the treatment that starts before the surgical incision will prevent the establishment of the central sensitization, and that reduce the subsequent pain experience, with the assumption that central sensitization has the major contributor role. But in post-operative, post-incisional pain is, it is the central sensitization is not the bigger role. The peripheral sensitization is the much bigger role in the post-operative pain, especially after the incision. This is the central sensitization is the bigger role in the chronic pain, especially the fibromyalgia and other things. This is a little bit different from that chronic pain, and little bit different from the regular post-inflammatory pain. That is the major contributing in development of the and maintenance of the post-operative incisional pain related behavior. That's why sometimes we don't have the good results with the preemptive analgesia, which you drugs, usually the NMDA receptor antagonists are selected. So it argues further the timing of initiation of the analgesia may not be the important, as the duration of the efficacy of the regimen is the more important, because you have to give that you have to take care of the not only the preoperative period and postoperative period. That way, the efforts to minimize the neuronal sensitization and hypersensitization should be extended into the postoperative period. That is called preventive analgesia. The preventive analgesia will be the better choice rather than the preemptive analgesia. So why that is the early reduction in the pain behavior with the spinal morphine, bupivacaine, or NMDA receptor antagonist has no impact on subsequent pain behavior beyond the duration of the expected analgesic effect. That's why the preemptive analgesia is still arguable. Some people are still doing. I don't have that any idea of against preemptive. Concern about the preemptive analgesia. The most important thing is that you should not stop yourself into the preemptive analgesia. You have to take care of the perioperative period. That's why the patient will have the good pain relief. That is called.
Kumar, we'll have discussion started. Kumar, yeah.
Yes, sir. Finished it, sir. Conclusion, sir.
Yeah.
So the
no,
conclusion,
we'll give
sir,
time for the questions because there will be a lot of questions. That's the reason why.
One slide, sir. That's all, sir.
Yeah.
Finished, sir.
Thank you.
So this is the thing. Previously, we used to give the post-op analgesia for all towards the IV and other things. Now we are reduced to that. After that, it's evolved towards the neuraxial and nerve block. Now it is into the peri-incisional, wound, periarticular incision. That thing. So with it conclude the few points. The post-operative pain mechanism is not a simple one as we think of. It's a complicated lot of receptors, mediators, neurotransmitters. That's why we need multiple techniques, drugs, and methods to make it as a multimodality. And no universal formula is available to take care of that. Recent developments are promising. The genetic modulation is the one other thing we have to keep in mind, and we have to keep it updated to tackle this kind of the pains. And these are the references I have taken. And thanks a lot for our patient listening, and thanks a lot for a wonderful opportunity. Thank you for all, sir. Thank you.
Thank you, GK Kumar sir. It's a nice presentation. You have just highlighted the importance of post-op pain management, and you had given more thing for multimodal approach. I think in India, the post-op pain management was significantly reduced in the last few years. The data given maybe from US, in India, I think it has been significantly reduced, mostly because of the regional techniques and training programs. And also, I think the inclusion of pain clinic in Department of Anesthesiology by MCA. So that are the one more important thing. We are very able to control those post-op pain. We had few questions, sir. Can we start discussing?
Yes, sir.
Yes, please.
Yes, sir.
Okay, sir.
Quickly we'll go.
Yeah, yes, sir. We will take only short minute. The first question.
No, you take time for discussion. There's no problem. The idea is to give a lot of time for discussion.
Okay, so it was a practical question. The first question was a practical thing. So the question is why a patient with RTA with multiple fractures don't complain about much pain than a person who had undergone a hernia surgery, a simple surgery. So he told, okay, the recommendation is why can't we go for a proper study? So is it the way, or it's you want to add something?
So obviously, the trauma patient will have that apart from that persistent stimuli. I mean, the nociception is more, his psychological factor is also there, rather than the patients posted for elective cases. It's obvious. And apart from that, all kind of the tissues are getting damaged in a thing, and a lot of inflammatory response will be there, and there will be the nociception from the skin, deep muscle, and even the bone will be there. There is the one. This is the you have to go through the basic mechanism of the pain. When there is the two model, that animal model they did it. One is the simply incising the skin, and again model they did retracting the gastrocnemius muscle in the animal model. But unfortunately, there's obviously this so it's involved at the deeper tissue will have the more amount of the spontaneous activity of the neuronal tissue was there. So definitely the nociception is more, and multifactorial is there. It's obvious one. So it is not a strange thing with the trauma patient will have that lot of pain.
The thing is, he says that they will have less pain. So it depends on, I think, to add up, I think it was because of the descending inhibitory pathway. So we are not focusing more on descending inhibitory pathway. So if the descending inhibitory pathway is well enough, most of the patients don't feel pain, whatever about the surgeries. But I won't accept this, because if you think about these things, most of the trauma ICU will be calm than post-op. I think in practical purpose, post-op ICU is always calm than trauma ICU. The next question is, what is the role of gabapentin in fracture pains?
So the gabapentins are mostly associated with used for chronic pains, but their role is very much limited, and they have the variability among that. The most fearsome is avoiding the gabapentinoids or sedation. So this is a prolonged sedation is there, but definitely the gabapentinoids are some of the studies which encourages the users, especially the orthopedic cases. You can use it, but though you have to be very careful. The perioperative sedation is very, very high, especially the Indian populations are very much sensitive to that. You know that they will not tolerate even 75 milligram of the pregabalin. And whereas in Western countries, they used to starting doses around 300 milligram, which never reached in my patients. And Guru, you will be the better person to share the experience of the response of the gabapentinoids in our, especially the Indian patients.
Yeah, yes, sir.
One more point, Gurumukh sir, one more
Yes,
point.
sir. Yes,
He has rightly said pregabalin and gabapentin is only for chronic pain. They recently published in 2020 anesthesiology. There is a systemic review and meta-analysis. They have advised routine use of pregabalin and gabapentin for the management of post-operative pain should be deferred. They are not supporting the gabapentin and pregabalin for acute post-operative.
That was very recent publication, just recently. Yeah.
The thing
So
is,
I have seen many postgraduates are still doing pregabalin and gabapentin for post-operative pain relief. So it should not be continued.
Yes,
according to the meta.
you are rightly said, sir. The mechanism itself is different. It is nothing to do with inflammation. It's mostly on the descending inhibitory pathway. So maybe most of the people would have started using pregabalin, gabapentin, thinking about the central sensitization to avoid chronic pain syndromes. So it won't prolong, or it won't have any impact immediately. Only the sedation may have some impact on the patients. The patient will be lying calm, nothing more than that. They would have studied only for prevention of chronic pain. As you told, it has no role for acute pain control. So it is only for chronic pain. So most of the pain clinic cases, what we usually receive in post-op cases, after 1 month, they will send the patient suspecting CRPS. So most of the post-op patients, they suspect CRPS and send to us. And we feel that most of them won't sit in CRPS. They never satisfies Budapest criteria. So we found that most of the patients develop this pain, mostly neuropathic pain, only because of inadequate pain control during intra-op. So we simply start on these gabapentins, and most of the patients respond very nicely. So it is usually used only for chronic pain. That we accept, sir. So there was 2 questions on post-spinal headache, sir. I think that it was a question of post-operative spinal headache. I think it was post-dural puncture headache. So how to manage, sir?
Very obvious one. Post-dural puncture headache is a little bit not related to the topic. For the postgraduates, it is a post-dural puncture headache. Most important thing is the recommended posture is the one thing we have to do. That again, hydration and other things are there, and a simple parenteral analgesics will be helpful. If it is not going to be helpful, the other drugs will sit there. But you can do the blood patch and saline also. You can try that. Anything else? Better to have the other people add.
What about the spinopalatine block, sir?
Yes, sphenopalatine block is the one of the promising one, which is a simple one. You need not to go for intervention one time. Such putting a small swab, which is soaked in the local anesthetic, will be put into the inferior turbinate, and we have to push it to that, and the patient will definitely have that immediate pain relief. That is one of the useful. It will use as both the way diagnostic as well as a therapeutic. Few of my patients are managed like that, but but it usually it responds to the recommend and hydration and other conventional things. One the resistant PDPH, you can try this one. But I used to do that as a diagnostic as well as the therapeutic. I don't have the patience of going by these step by steps, and when the PDPH coming to me and everything would have been tried. That's why we directly go to the simple sphenopalatine ganglion blockade.
I just want to add, sir, that sphenopalatine ganglion block. So when we are going in the pain practice, so when you look at the indication of sphenopalatine ganglion, there will be n number of indications. So we always try as the final result. So everything we tried, nothing working in head and neck area, even for this post-stroke pain syndrome. Finally, we think about parasympathetic. So sphenopalatine is parasympathetic. We will go for diagnostic and try. And even for PDPH, I think most of the patients respond very well to those hydration, and even for most of 95% of the patients will respond to our blood patch. I think very rarely they go for sphenopalatine ganglion block. But I also add to one thing. So most of the people think PDPH, most of the patients will come after 5 days with headache. So those patients who had headache after spinal presenting after 5th day, always think about other red flags. Always never think about PDPH. Most probably they will have some intracranial hypertension or intracranial something going on there. We had few negative things happened in our practice. I just want to tell any patients coming on the 5th day with a severe headache, onset after 3rd to 5th day, most probably it is not PDPH. It is something else.
So PDPH is usually getting diagnosed by relieved by patient lying flat. This is the most important clinical sign. You have to diagnose. The only thing you need to diagnose the PDPH, because no other modality or any other specific clinical sign or investigations you need. And this is simple. Patient should have the spinal and should have relieved by the lying flat. Definitely the diagnosis of the PDPH. And again, sometimes the patient may have the PDPH even after the 7 days. So you need not, that is, you have to keep in mind, PDPH is not the thing which should be happened within 48 hours, something like that. We have the quite few patients coming to our pain clinic. We'll have the even after the 7 days they have the pain and other things. This again, it's more prone in female patients with younger individuals.
So the next question, I think he itself has given the answer. So most of us, we use tramadol for post-op analgesia. So what about in post-craniotomy, especially in neurosurgeries?
The tramadol is the one thing which we shouldn't forget, that it is epileptogenic. So whenever the central nervous system cases are that it is a drug relatively contraindicated, you can say that it's totally contraindicated. We have the other drugs rather than the other opiates which can be given. Tramadol is another good choice to select, especially in parenteral route. And again, the tramadol in epidural and other things for other cases. Tramadol is not much increasingly the duration of the co-administered local anesthetics. Is hardly, it extends the action by only a few hours or 2 to 4 hours, maximum 4 hours only. So I don't believe in giving the tramadol in neuraxial or epidural. But tramadol is, to my knowledge, to be contraindicated in central nervous system post-operative pain relief.
Okay. So we had talked about the dexamethasone in our block, especially for prolonging the duration. The question is whether we can add along with the local, or is had any impact on IV?
Yes, there's a comparative study they did with 4 mg of dexamethasone and in the perineural blockade, especially it is not meant for intrathecal or epidural. It is highly encouraging results with the perineural blockade. Those who have the chance of hearing that lecture, which is delivered last week exactly by in the Kerala ASA web conference, Vincent Chan is the one of the pioneer in the ultrasound guided nerve block. He himself came with a lot of supportive studies to encouraging studies to support the dexamethasone, which is have the peripheral nerve block, which is not at all related to the systemic absorption. It's only 4 mg will have the prolonged effect of things, not much complications. We don't know the reason for that, why the same kind is not expected in the lower limb blockade. But at present, it is one of the very known and very well accepted, safe to have that upper limb blockade as an adjunct to the local anesthetic agent.
Edward, I think time is up, 12:58. We should wind up.
So before winding up, it's a common question. What's the opinion about the opioid-free anesthesia for both of you, Kumar and Gurumati, sir?
For opioid is we cannot live. For me, that is exactly contrary to what this Tulsar sir delivered the lecture. Before that, we need opioid for some kind of the patients, especially the chronic pain. Even though that we know that the opioid is not much going to be useful for neuropathic pain, but opioid is not going to be avoided. But opioid related complication can be definitely reduced by selection of the opioid, which opioid, and by the lot of novel route of administration is there. That will definitely encourage the opioid usage, and by adjuvants, selecting the adjuvants also, we can reduce the opioid related complications, especially post-operative nausea, vomiting, and respiratory depression.
Anesthesia, we can say.
Definitely, opioid plays a major role. I'm always for opioid in some other any one other form. Opioid free is always there, but at current scenario and coming years, I don't think we cannot avoid that opioid, especially being in chronic pain management.
And thank you so much for the speakers Ranjit and Kumar, and the chairpersons Gurumati sir and Kumar. We come to the end of our academic session. Over to Sudarshan. Sudarshan, are you there?
Kriba is there.
Akirba?
Thank you. Thank you, Dr. Thank you, Dr. Edward Johnson, for moderating the academic session. And we thank, on behalf of Tamil Nadu ISA, both the speakers and as well as moderators for their excellent performance today. And now we invite Dr. Bhaskar, Chennai ISA branch secretary, to give a branch report. Dr. Bhaskar, please.
Bhaskar, unmute yourself.
Good afternoon, everybody.
Yeah.
Sir, can you hear me? So good afternoon, everybody. I would like to thank the State ISA for giving us this opportunity to host this weekly webinar process. To start with, January 2020, we started with a routine CME session at Hotel Savera. And next month, we had the visit by the Tamil Nadu IS, the National IS office for the national body. And this was almost over. And when the final things are settling, the lockdown was announced, and the process has been stalled after that. And we have started our regular webinar process, sessions. We have conducted 2 sessions in the past 2 months. And I should thank the National ISA for releasing an emergency fund to buy the PPE kits and other needed for a safe anesthesia practice. And I also thank the state body for guiding us to where to procure those standard PPE. And with their help, we distributed the PPE procured at the time to major institutes where they were managing the COVID patients. And we are trying to coming back to the normal. And I shall just to thank the state ISA for going to organize the session for the postgraduate, for the benefit of the postgraduates. Thank you, sir.
Thank you, Dr. Bhaskar. Now we have come to the end of the session, and once again, I want to tell a few points about the PG Conclave 2020 to be conducted on 18th, 19th, 20th of next month. So we are making all the arrangements, and we are trying to get the creditors both from MGR Medical University as well as from the Tamil Nadu Medical Council. And we have an interesting quiz program for all the 3 days. So I request all the postgraduates as well as practicing anesthetists be ready to participate in this event. And I want to thank our Tamil Nadu Medical Council observer today, Dr. Ponraj. He is also our Krishnagiri Huzur ISA president for being present here. Thank you, sir. And next week we are having Tamil Nadu ISA webinar on 15th It will be hosted by the Krishnagiri and Hosur IAC branch. We have two interesting topics. Error 120, as well as one more topic is about geriatric anesthesia. So we will intimate you all the details in 2 days' time. And we thank all the delegates today for not writing their names and mobile numbers in the chat box and cooperating with us. We are very much thankful to all of you. And we thank both the speakers as well as moderators. And we thank our President, Dr. Sudarshan, Dr. Vice President, Dr. Kumar, and Dr. Edward Johnson, Academic Coordinator, and our Treasurer, Dr. Ratna Kumar, for successful conduct of this program. With this, we are winding up this session. And thank you once again. See you all at the same time next week on 15th. Thank you very much.
Happy Diwali to all of you.
Happy Diwali to all.
Happy Diwali.
Happy
Diwali. Happy
Diwali.
Diwali.
Advance Diwali.
Happy Diwali.
We can meet the day after Diwali. We'll meet.
Yeah.
Thank you.
Thank you, sir. Thank you, sir. Thank you, sir. Thank you very much.
Thank you.
Thank you, sir.
A big thank you to all the
Shilpa, we can close.
excellent